Thank you very much for the kind introduction. And it's always difficult when you come after an excellent speaker. I will talk about nail disorders with specific signs that can help you make the diagnosis from the first look. First of all, we know that most of the dermatosis can have signs on the nails. And most of these signs are not specific. They may look alike. For example, onycholysis, yellowish nails, red nails, and other signs. They may look just the same in different disorders. But sometimes these non-specific signs can have a specific presentation. For example, in onycholysis, all these disorders can lead to onycholysis. But when you have this sign, when you see this onycholysis with the red erythematous rim around the onycholysis, this is specific for psoriasis, nail psoriasis. In this study, they have compared onycholysis of 3 different disorders: nail psoriasis, onychomycosis, and traumatic onycholysis. And they found that this erythematous rim was present in 2/3 of the patients of psoriasis, and none of onychomycosis or traumatic onycholysis. And it was very specific statistically. The other sign in psoriasis from the same study is these red dots under the hyponychium, under the distal edge of the nail. You will find these red dots. They were very specific for psoriasis, and they were present in more than 2/3 of the patients, and none of onychomycosis or trauma patients. So these are 2 signs helpful to make the diagnosis of nail psoriasis when you have a patient with only nail psoriasis. Then the yellowish nail. We know that most of the patients with yellowish nails are diagnosed as onychomycosis, sometimes without proof, without culture, without KOH. Most of the doctors are treating onychomycosis based on this presentation. Yellowish nail, it's almost always an onychomycosis. It is true that it is the most common cause of a yellowish nail, xanthonychia, but it is not the only cause. Here are 2 signs. When they are present in the nails, you have to think about another disorders. When you have this transverse over-curvature of the nail plate, and when you have these linear ridges of the nail surface, you have to look at the distal end of the nail. And if you find these honeycomb cavities, it is onychomatrachoma. So a yellowish nail is not always onychomycosis. Here is a picture of MRI of onychomatrachoma. We see that the tumor is going from, I don't have the laser here. Yeah, we can see the tumor from the nail matrix, and it is actually a nail matrix tumor arising from the dermis of the nail matrix with these finger-like projections extending into the nail plate itself, which causes the cavities. And sometimes if you don't want to do the surgery, you can make the diagnosis with only clipping of the nail plate without any anesthesia. Just cut the distal edge of the nail and send it to histopathology. They can make the diagnosis. In this picture, candy canes is a sign for nail disorders. Some nail disorders, if you see this red and white lines in all of the nails, this is specific for Derriere disease, and it is called candy cane nails. Some other signs of Derriere disease are these candy cane lines of the nails, and sometimes you have the distal wedge fractures of the nails, and this is more important and more specific when you have these keratotic papules under the nail itself. Ventral pterygium, it can be caused by traumas when it affects only one nail, but when you see it on multiple nails, you have to think about systemic causes. And here you have also the distal ulcers on the nail fingertips, and these are specific for connective tissue disorders, mainly scleroderma, but it can also be seen in dermatomyositis and lupus. Another sign that would help, or another examination that would help to reach the diagnosis when you see ventral pterygia, is to look at the proximal fold capillaries. You can do a video capillaroscopy And there are three main patterns of these capillaries. The normal pattern, regular parallel lines of capillaries. When you have disorganization, this is a lupus pattern, but when the disorganization is severe with megacapillaries, this is more scleroderma or dermatomyositis. And here are real pictures of these patterns. You see here the disorganization in dermatomyositis and scleroderma is more severe than that of the lupus. And actually, your dermatoscope has been shown to be comparative to video capillaroscopy. Lower sensitivity, but higher specificity than video capillaroscopy. So you can use your dermatoscope to look at these capillaries when you are in doubt. In dermatomyositis, we know these specific signs, especially the thick cuticle, which is specific for dermatomyositis, knuckle pads or Gottron papules on the knuckles, and here we can see the ventral pterygium on the little fingernail. These are two patients. I cut the pictures because it is easy to make the diagnosis with the whole picture of it. But when you see a nail with just linear fractures, only one nail in a kid, this could be caused by lichen sclerosis. Lichen sclerosis, when it affects the nail matrix only, it causes these linear fissures of the nail. For example, in this patient, he didn't have any skin lesions, but you see that only one finger is affected with longitudinal fractures of the nail plate itself. If you focus, you can sometimes find monomorphic papules, micropapules on the proximal fold. But this patient, in lichen sclerosis, you don't need treatment. They will improve by themselves with time. Another sign, in the longitudinal grooves, when you have a groove or a depression which is longitudinal on the nail plate, it means that there is something making pressure on the nail matrix. It could be a tumor, it could be a fibroma, it could be anything. But when this groove is wavy, when you have multiple waves, this means that the tumor itself is inflating and deflating. And the recurrence of this inflation makes these waves of the groove. And these cases are all conditions of pseudomyxoid cysts of the above the nail matrix, which makes these waves of grooves on the nail plate. And the treatment that have been reported for pseudomyxoid cysts, all the treatment have been reported and none of them was 100% successful. The most simple one is the aspiration and a tape for 1 or 2 months to make pressure on the area of the pseudomyxoid cyst and to prevent the recurrence. You can use, there are some reports for intralesional triamcinolone, cryotherapy, CO2 laser. I like the CO2 laser because it causes shrinkage of the tissues and fibrosis, which could block the leakage of the fluid from the joint. Sclerosing agents have been tried, and they are very effective in treating these lesions. But the problem is that there is sometimes a leakage of this product into the joint, making some stiffness of the joint itself. I will not talk about this very specific and known sign of gout, the tophi of gout. Also, there is the Cohen tumors are specific for tuberous sclerosis when they are present in multiple nails. But there are another sign which has been reported recently in tuberous sclerosis, which is seen in early cases before the appearance of the fibromas. You can see sometimes the comets in the nail bed, and you can appreciate it more with the dermoscopy. You can see the comet, the red comet, which is a dilated linear capillary with the surrounding whitish area, and this has never been reported in any other disorders. Onychorexis and dorsal pterygium, if they affect multiple nails, of course, this is specific for lichen planus, but some other disorders may share the lichenoid presentation. And here are some of the examples. It has been reported in amyloidosis, sarcoidosis, GVHD, and dyskeratosis congenita. They can have the same picture of lichen planus. And in kids, this patient was referred to me for this presentation, and they saw this pterygium, and the referring dermatologist was asking about if this could be a lichen planus at this age, 2 years old. But there is a very specific pathognomonic sign in the other nails. If you look at some of the nails, you see this triangular lunula here, and you see it here. And this triangular lunula is specific for nail patella syndrome, which is an autosomal dominant hereditary disorders. And these were the pictures of his mother, and she had the same thing, dystrophy of the thumbnails and triangular lunula on almost all the nails. So this is very specific for nail patella syndrome. Nail patella syndrome is not only a nail problem, some skeletal problems involving the patella, the elbow, and the iliac crest are usually present, if not in all patients. Ophthalmologic complications also sometimes are seen in these patients, and nephrologic complications. So these patients have to be followed up by a dermatologist, but also by an orthopedic surgeon, an ophthalmologist, and a nephrologist. In this case, I think it's my last sign. In this 63 years old female patient, she also had a lichen planus-like presentation with this onychorexis, but she also had, it was an acquired condition. She had also discomation or scaling around the nails, which started in periangual tissues and then spread to involve the whole fingers and the palms and heels. But in these cases, the central part of the heels and palms is spared. So there are discomation starting from periangual tissues, spreading proximally, reaching the heels and palms without touching the central area of the heels and palms, with some nail changes. And this was a basic syndrome, acrokeratosis paraneoplastica. And in this report, nail changes were present in 80% of the patients, and almost all patients had changes in the periangual tissues. These nail changes are usually psoriasis-like changes with thickening, hyperkeratosis, yellowish nail, but some patients may also have a lichen planus-like presentation. So whenever you see nail changes with periangual scaling, which spreads progressively, you have to think, especially in old patients, you have to think about this paraneoplastic syndrome. So these are my take-home messages. Again, all the pictures to remind you of the signs, the erythematous rim in psoriasis, and these cavities in onychomatricoma. If you see regular whitish and red lines on the nails, you have to think about the candy cane, and you have to think about Derrier disease. Any patient with a triangular lunula, think about the nail patella syndrome and ask about the hereditary, the parents especially. Ventral pterygium in connective tissue disorders, you have to look at the proximal nail fold capillaries. And the wavy gutter is specific for pseudomyxoid cysts. Lichen planus and lichenoid presentations in the nails and the periangual tissues, which sometimes can be paraneoplastic. Thank you very much, and thank you for the organizer for the invitation.
Thanks very much. Thanks, Dr. Azzam. Hello. Thanks, Dr. Azzam. It's very interesting, very spot on. I mean, we have time for 2-3 questions. Any questions from the floor? Okay. It looks like your presentation is very clear, spot